let's, Larry, you and I kick it off formally. Co-chairman Dr. Larry Steinman, preeminent therapeutic developer, neurologist, immunologist, and man for all seasons. I'm honored to be his co-chair and co-founder of this conference. And we are honored to have all of you who are joining us today from across the globe. And indeed, our panelists throughout the day will be across the globe. And so this truly is an international community. And it's one that focuses on what I believe is one of the most important objectives of the life sciences, and that is to do something about modifying the aging process and preventing age-related chronic diseases. That's why we're all here. It's the tie that binds our interest across our many different disciplines. So Larry, good, very, very early morning to you in Palo Alto.
Thank you very much. And it's a pleasure to kick off day two. And as Fareed Zakaria says, let's get started.
Okay. Well, then a man who needs no introduction, Jay Skyler, who did a wonderful job in leading the first panel yesterday morning. Take it away.
Thanks, Zan. And it's nice to get to participate in Metabesity 21 Live. We've got several panelists. You've already heard from an introduction of one of them, Larry Steinman, but I'm going to ask the other panelists to go ahead and introduce themselves briefly, and we'll start with Vivienne Lowe.
Okay, so I am in the Boston area. I am an internist and obesity specialist, and I've been working on metabolic health with my patients for the last 6 years in my own practice, and also recently joined Inonio Medical as their medical director. But I have been working in this field for about 20 years.
And what does Anodia do?
So what doesn't it do? I would just characterize it as a completely outside the box paradigm for healthcare, which I find really exciting. Combining the interests of both patients and also healthcare professionals to really kind of change all our notions and our experience of healthcare.
We'll let you tell us more about that as the panel goes on. We also have Jennifer Ligibel. Did I get that right, Jennifer?
You did.
That pronunciation?
Yes. So good morning, everyone, or good afternoon, depending on where you are. I am a medical oncologist at Dana-Farber in Boston, also along with Vivienne. I work in our breast cancer group and also do research that looks at how nutrition, physical activity, and weight management impact cancer risk and cancer outcomes for common diseases, especially breast cancer.
Great. We have one more panelist who the Zoomistas, I think that's what they're calling them. They're the technical people that run all of this, are trying to find what happened, where he is, and that's Dale Abel, who is chief of endocrinology at the University of Iowa, and particularly interested in how diabetes and the heart work together or apart, or how diabetes affects the heart and the heart affects diabetes. So hopefully Dale will join us shortly so that we can round out our panel. But the main issue that I would like each of you to address is to come up with 2 or 3 interventions or other measures that stand out as ready to test in and adopt as candidates for clinical trials for delivering multiple outcomes for all of the age-related benefits. And let's start with Jennifer.
Sure, absolutely. So I think one of the things that is so striking in cancer research is that over the last decade, especially, there has just been an explosion in new treatments. We really have completely upended the paradigm with which we treat patients with things like immunotherapy. We use more and more targeted treatments rather than chemotherapy, which sort of has a broad effect both on cancer and normal cells. But there have not been similar advances in cancer prevention. In fact, there are really no new agents or strategies that have been approved for this purpose in many, many years. And with the exception of selective estrogen receptor modulators and aromatase inhibitors to prevent certain types of breast cancer, and things like colonoscopies and early intervention to prevent colon cancer, the prevention studies that have been conducted have really not been successful. There are a lot of reasons for that, but this is really a huge area that when we think of age-related chronic diseases, cancer certainly ranks very large amongst them. And so, one of the things that in my work has really been striking is the amount of observational evidence that has mounted, suggesting that lifestyle behaviors, physical activity, nutrition, weight management are important in preventing cancer. But it is very difficult to tell people that they just need to lead a healthier lifestyle. And so there's really a need to develop precision prevention interventions that really utilize different types of lifestyle change to determine whether that could prevent particular kinds of cancer. And that in order to really do this successfully, we really need to have a better understanding of the biology that links these types of lifestyle factors to cancer, not just in the population, but in individuals. So we need to have a better understanding of what we call precision prevention to be able to identify the individuals for whom a particular risk factor, whether it be obesity or inactivity or a dietary part of their diet, whether it's something they're eating, something they're not eating, that is driving their cancer risk, to be able to intervene. And this will take us away from these 50,000 person studies, which unfortunately, when you look at things like the Women's Health Initiative, the SELECT trial, have really not been effective in preventing cancer. So, I think that what we need to be able to do over the next years is to be able to figure out who is at risk of cancer because of a particular factor, and then deliver targeted interventions to those individuals.
That's the hard part, though. Figuring
It
out
is the hard part.
Who
But
is
we
at
have,
risk, because the interventions you could propose, but you need to know exactly who to propose them to. And I think that still requires the large trials to look for which risk factors occur with rich people.
it is true, but there has been over the last few years advances that have been made looking at a number of different SNPs and things that are related. Because I think what we're recognizing more and more is the convergence between the genetic and the lifestyle, and how these factors don't impact everyone the same. And so there has been progress in that arena. And I think there are more studies at this point that are ongoing looking at how these types of changes affect cancer outcomes as compared to cancer risk. And that is also helping drive the field of prevention forward. We do have a number of large-scale studies underway looking at whether changes in lifestyle could prevent recurrence and increase longevity in individuals who are already diagnosed with cancer, especially breast cancer, colon cancer, and prostate cancer, which are malignancies that seem to be the most impacted by lifestyle factors. And so those studies will also help us move forward. There are very rich biobanks that are being established in those studies, which are also large scale, but on the order of 2,000 to 4,000 patients instead of the 50,000 that you would need for an unselected prevention study.
Okay. First, let me welcome Dale Abel. Dale, I mentioned who you were, and welcome.
Thank you. I apologize for being a little bit late.
You probably were like me. I got one email that said we started at 9, one at 8:45, and one at 8:30. So it can make it interesting. What we're talking about is interventions or other measures that stand out as ready to be tested clinically to deal with multiple age-related conditions. And I think Jennifer, who started first, mentioned two things that are relevant to. She talked about lifestyle, and I'm going to ask Vyvyane to comment on lifestyle because that's one of the main things that you do. But she also mentioned immunotherapies for cancer. And Larry, that comes back to your area of expertise. And for example, some of the things that we might use for cancer, you could use the flip side of that. If you're using an antagonist for cancer, you could use an agonist for autoimmune diseases, which occur as we get older too. And I want to know how we sort all that out. So let me start with you and that, Larry, to expand on the use of immunotherapies in general for the aging conditions. And then we'll get to Vyvyane for the lifestyle, and then we'll get to Dale.
Well, my contention here is that why go experimental? Why go for delicate moonshots when the simple and ordinary will have the biggest impact? And I borrow this from COVID. The vaccines are great, but before we have the vaccines and after we had the vaccines, simply wearing a mask makes a very big difference. So one of the most notable risk factors in inflammatory diseases of the brain, ranging from Alzheimer's, dementia, to a disease like multiple sclerosis, is obesity. So when you arrive at the time where you have early cognitive decline, or you arrive at the time where you've had your first attack of MS and you find yourself obese, you can't reverse an entire childhood and early adulthood, and maybe a longer period if I'm talking about Alzheimer's, by all of a sudden changing lifestyle completely. So what I would like to know, and what I think everyone would like to know, is will a sensible increase in activity and a sensible increase in weight loss related to increased activity have an impact, in the same way that if you were a pack-a-day smoker, will stopping once you're diagnosed with a cancer make a difference? I'm not so sure that stopping smoking after a pack a day for your previous pre-diagnostic life makes a difference, but for brain diseases, I really would like to know. And for that, we might need a 50,000 patient study stratified appropriately. But before talking about wonderful advances, the flip side of checkpoint inhibitor therapy to attenuate autoimmune responses, I want to go back to the more mundane and less noteworthy, the equivalent of wearing a mask. Move a little more. It has an amazing impact longitudinally on cognitive function. But that's the conundrum here, is that the ordinary changes are the ones that will have the easiest way of implementing and might have a huge effect.
Well, the person who implements some of that is Vyvyane. So tell us about your thoughts on this and lifestyle in particular.
Just very quickly, the evidence is pretty clear. You can't out-exercise a bad diet. So I think we really have to start with nutrition. And I think most people have generally jumped to lifestyle change by going to the gym and trying to sort of work off the calories. And we've seen that that just hasn't worked. Before I jump into lifestyle, I think one of the things we need to address is how we are looking at obesity, which is sometimes a little frustrating to me because we're only focusing on the fat mass problem. We're not focusing on the dysfunctional fat problem, right? There are two components to obesity. And when you see a patient, you have to be considering those two things. So yesterday, when I listened to some of the panelists, they were talking about how you don't even need to be obese because, I've seen lean individuals with really bad metabolic syndrome. And that's because we're focusing primarily on the fat mass problem and not on the dysfunctional fat, right? So at my clinic, we often talk about normal weight obesity. And, we're primarily targeting visceral fat and other forms of ectopic fat. Right? It's hard to measure, let's say, fat in the heart and so forth, or even in the liver, but it's easy. If you do a Dexa scan, you can get some approximation of visceral fat. So you can have a target that you are treating, and you can discuss that with the patient, because patients come to us and they are referred to us by providers with this notion of, I've got to lose weight. And I go, well, we probably need to get rid of the bad fat. I do not want you necessarily to lose weight, because part of that weight loss might be muscle loss. And if we're not, thinking in those terms, then every time you tell a patient to lose weight, they are going to lose some component of muscle mass with the fat mass. And as we go along, we're going to start to see the body composition change with time and over age, right? We already have anabolic resistance as we age. And so that muscle, the lean compartment is going to shrink. The fat compartment is going to increase. Now, with breast cancer, I'm sure Jennifer knows this, that even at a normal body weight, you have increased risk of breast cancer if your percent body fat is higher. Right. So we should be looking at those nuances and not just looking at a weight issue. And this is one way. I think, Jay, you brought this up yesterday in the first panel where, we're talking about how people now glorify obesity, right? And you can't even talk about obesity. And I think that there's a lot of shame that goes with the diagnosis of obesity. And therefore, I really try to focus the patient on the metabolic dysfunction. And I can't tell you how many times I have had patients bring in a family member, usually a spouse, who is lean and he or she never had a problem with their weight, right? And then you throw them in the Dexa and they are just, mostly visceral fat. And this really changes it for my patient, because they have felt like, oh, I'm the problem. I've been the problem the whole time. And now it opens their eyes. And this is actually more prevalent than we realize. There was a study in 2014. It was done in Italy. And by BMI, in that population of women that they looked at, about a third were, obese. But when they looked at percent body fat, we jumped up to 70%. So consider this. As of 2018, the prevalence of obesity by BMI in this country is 42%. If we were to go by percent body fat, I'm being conservative. I think it would be 90%. So if we're thinking that way, then you look at people with very different eyes, and you're not just, making a diagnosis or an assumption based on how someone looks. So I think that part is really important, and what I would really like to see, because the technology is already there. Just like Larry said, there's so many things that are available that we're just not utilizing to their full potential. So doing a body composition by Dexa, which has low radiation exposure, and you can follow people sequentially. I can even look at lean mass in one arm or one leg. So, you can compartmentalize where the lean tissue is, where the fat tissue is to a certain extent. You can see if it's subcutaneous or visceral. So that's much more useful for me as a clinician, and in setting a metabolic goal with my patients and getting them to understand it's not necessarily weight I need you to lose. It is really that dysfunctional fat. So that's one. And then World Health has always talked about the double burden of obesity. And by that, they mean that in the same individual that has calorie excess or overnutrition, they also have malnutrition, right? Because they're consuming foods that are nutrient poor. And I think of that as occurring in developing nations, but we actually need to start thinking about it in this country, because I see it all the time. So when I see someone with quote unquote obesity, that I'm always keeping in mind, all right, really, what's the body composition, fat mass, dysfunctional fat, nutrients, right? So for example, in my population of patients, let's just take one nutrient, let's take B1, okay? If you have thiamine deficiency, right, that is going to, increase the risk of many other issues. Zan started talking about type 3 diabetes, which is the dementias that we're so worried about, right? And people talk about insulin resistance in the brain. And really, let's think about this, right? The brain is not an insulin sensitive tissue in terms of GLUT4. It's really GLUT1 and GLUT3. So we shouldn't be worried about glucose not getting into the cells because of insulin resistance. And insulin resistance in the brain, to me, has always been, as far as I know, about feeding behaviors and so forth. But, you know, what we're seeing with dementias is glucose hypometabolism. So for some reason, we're not able to utilize that glucose. And in a fair population of those patients, if you trace it back, it could be thiamine deficiency, right? And if you've had a lifestyle of overnutrition, poor nutrients, and you're consuming a lot of complex carbs, you utilize your thiamine pool. And so if you're not replacing that, and if you do replace it, making sure you replace it with a good absorbable and bioavailable form of the nutrient, right? Then we're really not going to address the entire issue because we're just so focused on the weight. And Dale, I'm glad you popped on because I was looking at some of your studies, which were fascinating, on the failing heart, the metabolomics of a failing heart. And you had mentioned there is a backup in glycolysis. Mm-hmm. And I had wondered and thought about this, whether, you'd looked at thiamine deficiency, for example, in those models. And at least I know you also talked about, I think, 2 oxyglutarate backup or buildup. And we do see that with B6 deficiency. These are all coenzymes in the TCA, right? So we can't utilize that TCA cycle if we don't have the nutrients available.
Yeah, so I mean, that's a really, interesting point, and I think a good segue. So you're correct, Vivienne, that, there's this kind of overlap of what I'm going to call the cardiometabolic state with, with obesity, insulin resistance, the risk for type 2 diabetes. And, a long time ago, we thought it was very just fairly simple in terms of, the heart may have switched its substrates. So what we're seeing now that we are applying these much more sophisticated metabolomics tools is that really what's happening is much more nuanced, is that the glucose carbons, when they come in to the heart, are being kind of misdirected. And they're being misdirected because certain key metabolic control points are not allowing it to go all the way through to complete metabolism. And so, I think the notion that could some of these enzymes, for example, involved, say, in the TCA cycle, even some of these enzymes involved in glycolysis, we know that they are subject to regulation by many of these, vitamin cofactors. And we don't yet fully understand why we are having this misdirected traffic per se. So I think you raised a very important point. And so I don't think anybody's really looked to actually see, for example, if you, either measure for, the tissue levels of some of these, or you supplement to actually see what might happen to flux. But I think you raise a very important perspective for studies, moving forward. I think the other thing to kind of bear in mind as we kind of think about, metabolism and heart failure is that, as somebody becomes, say, more insulin resistant, right? And, I would say that obesity, as you know, is an insulin resistant state, but heart failure is also an insulin resistant state. And many people have this overlap where if you look at people with heart failure, nearly half of them are insulin resistant or nearly half of them have diabetes, right? So we really have overlapping syndromes. And so, as if you can imagine like the heart as a sort of, a sponge, it has to eat, right? And so as glucose levels rise and more glucose comes in, unfortunately, more glucose carbons get misdirected into pathways that then, either promote inflammation or, ventricular remodeling, etc. So a lot can be said about things that individuals do. There's a lot of discussion earlier on terms of, prevention, not to even get to that point. And so I can only just really amplify and underscore how critical it is not to get there, in the first place, because it's kind of hard to sort of, go in and fix 7 or 8 or 9 or 10 enzymes, right? Which would potentially be impacted by a plethora of other cofactors. The last thing I would say is that I think somebody had mentioned before in terms of, how can we understand a bit more about these cohorts so we can have more precision in our clinical trials and things of that nature. And I think that there are many now in the field who are doing, I think, very elegant studies looking at, deeper metabolomics profilings and proteomics profiling. And, preliminarily, I'm aware of, clusters of metabolites or even clusters of changes in the proteome that seem to be linked with specific morbidities in the cardiometabolic syndrome. And so I think that as those studies become reported, we'll have even deeper insight as to what some of these underlying mechanisms might be. And I suspect that some of these metabolomic studies will in fact begin to reveal some of the things that you are hypothesizing in terms of cofactors, et cetera, that might then be, having these secondary effects in the cardiovascular system.
So Dale, I wanted to ask you a question. You're talking about the glucose being misdirected. And it's known that the heart can consume ketones as a source of fuel. And there are even some who've advocated that with impending heart failure, one ought to go on a ketogenic diet to provide those ketones for fuel for the heart. Is that a good idea, or is that taking things a little too far?
Yeah, that's a great question. So, there are ketogenic diets, and then there are ways to supplement ketones in your diet. And I think we have to make a distinction between the two, right? Because essentially, a ketogenic diet is a diet that basically tricks the liver into making more ketones. And to do that, you have to restrict some things, right? So either you restrict proteins, or severely restrict carbohydrates, or you increase the fat in the diet, right? And so basically, the liver then kind of pumps out all these ketones. But what we don't fully understand is, well, what is the impact, for example, of either reducing protein or reducing carbs in order to get to that point. So there have been studies now looking at, and this is largely by Zolta Rani at the University of Pennsylvania, remarkable studies where they actually went to the EP lab, and when people are catheterized, they actually run a catheter into the coronary sinus and one into the right ventricle, so they actually could measure extraction of metabolites across the heart. And what was very clear is that the reason why ketone use goes up in the failing heart is that because there's just more ketones available, right? And so when you go on a ketogenic diet, or you take supplements to increase your ketones, the heart will happily use it. So then the question then becomes, what is the consequence? So I would say that if you increase your ketones, and we have shown this experimentally, that you actually reduce how much glucose the heart uses. And so in one sense, if you believe that, in our hypothesis that there might be a certain element of, glucotoxicity in terms of, all these aberrant glucose carbons, then what we've seen is that when you increase ketones, you actually reduce the amount of glucose that you take in. So, hypothetically, that could be a good thing to the extent to which you believe that this might be pathogenic, in the context of heart failure. I think the challenge, though, is how do you get there? So, if you're going to be restricting other nutrients or increasing other things to get to that state of ketosis, I don't think it's yet fully clear whether or not you're now sort of creating another situation that could then, lead ultimately to maladaptation. I think that ultimately the best studies, which I know are being designed and are being planned now, are going to be those studies in which you try to raise ketones kind of, and there are companies now making like ketone supplements and things like that to make them more palatable, right? You're going to raise ketones because the heart will happily use it without necessarily affecting the other macronutrients in a big dramatic way, like branched chain amino acids and so forth. So I think more to come, but certainly represents, I think, a very exciting area of potential nutritional modulation in terms of cardiovascular outcomes and heart failure outcomes. I'll say one more thing, because there's a lot of eminent people on this panel and a lot more to say than me. But I think we should also be thinking a little bit about what we're rapidly learning, for example, about SGLT2 inhibition. It's remarkable in the sense that there's this dramatic heart failure effect mechanism still to be determined. Some of it might be metabolic, but I think some of it might also be, renal, in the sense that not only is it hemodynamic, but I suspect, talking to folks in this field, that the kidney is probably making some other things that we don't know yet, know what they are, that are then having these, profound cardiovascular benefits. So I think that there's a lot of excitement as we begin to understand mechanistically, that relationship, and that might then drive to better prevention strategies, for example.
So speaking about ketones, one of the organs that doesn't use ketones very well is the brain, Larry. If we end up diminishing glucose availability because we're going on a ketogenic diet, are we harming the brain?
Well, no, not necessarily. For years, well before ketogenic diets were ever in the popular sphere, we've been treating intractable epilepsies with ketogenic diets with great efficacy and apparently little harm, given the problem that we're dealing with. There may be harm, but it's an extraordinarily useful tool for us in the armamentarium of anticonvulsants. So first pass answer is no, ketosis is not necessarily harmful. It has a potential benefit. Getting back to what Dale was mentioning about distortions in metabolic pathways, I just want to remind everyone of Otto Warburg's observations of, we're now getting to nearly the 100th anniversary of his paper about the Warburg effect. And it's a universal phenomenon, whether we're talking about the heart, the brain, and cancer. But one of the extraordinary opportunities in therapy for both inflammation and cancer is to design drugs that do their job a little better at 6.8 than at 7.4, and thereby increasing the therapeutic index. If the cancer, for instance, is running along at 6.8 and a checkpoint inhibitor can do a lot of off-site nasty effects like triggering autoimmune diseases a lot of the time. If these drugs were modified so that they would only kick in the Warburg milieu, one could increase the therapeutic index, to state it simply. And there are a lot of people working on it. But this could also apply to some of the well-known pathways associated with matters like hypertension that are really key as well in inflammation. And here I'm talking about the renin-angiotensin and angiotensin converting enzymes. Imagine if we inhibited ACE, but did it better when the pH became acidotic. These are all immense opportunities for intervention. So I've gone from talking about very low tech to very high tech, but you can engineer proteins that turn on at different pHs and turn on with different biological and chemical switches. And that's, of course, there are a lot of biotech companies and a lot of academic researchers working on that quite intensively.
So Jennifer, how often do we see cancer cells go to an acidotic pH where if you had an immunotherapy that only worked at acidosis, would that be sufficient to control the cancer?
You know, I think for one thing, cancer is definitely not one disease. And I think that you see that even as you look at the efficacy of something like immunotherapy, which has had broad applications, broader than most other targeted therapies in cancer, but there are very significant differences in the efficacy of, you look at something like a melanoma, there are parts of the system that are more immunogenic than others. For example, in breast cancer, immunotherapies to this point have been fairly disappointing other than in a narrow subset. So I don't think there's one answer to your question. I will admit that I am not a tumor biologist. And so I think it's an interesting theory, altering the pH. I will say also that there have been attempts to do this with, to change pH and to also enhance efficacy of therapies with things like intermittent fasting, which sort of take advantage of the fact that the normal cells and cancer cells utilize glucose differently. And so there have been some really interesting preclinical studies looking at intermittent fasting as a way of sparing your normal cells toxicity while enhancing the efficacy of anti-cancer therapies at the level of the tumor. Most of those studies are quite early and have been primarily preclinical, although there are a number of studies in advanced disease by Victor Longo's group that are looking at whether intermittent fasting may enhance efficacy of therapy in patients with advanced disease. So I think that is something that coming at this from a slightly different angle. I think it's really interesting, the thought of engineering drugs, but they're also kind of getting back to Larry's earlier points about sometimes a simpler solution can also be effective. I think there's a lot of efforts to try to see whether we can enhance the efficacy of anti-cancer therapies through dietary change. The other example of this is there's some really interesting work coming out of MD Anderson looking at immunotherapy in the microbiome, suggesting that perhaps dietary composition may impact efficacy of immunotherapy in patients with advanced melanoma, and specifically looking at fiber intake and microbiome in patients with advanced disease, initiating therapies demonstrating that individuals who have higher fiber diets may have a better response to immunotherapy compared to patients without. So I think that there are definitely sort of, again, getting back to the sort of lifestyle therapy interplays, that there are ways that you could potentially change the host through lifestyle factors that may help therapies work better.
So Vyvyane, I've got a couple questions that have come up from that for you. Does intermittent fasting impact visceral fat, or is it just general, is number one. And number two, the other question I have is, should we be doing Dexa scanning routinely on annual physicals, just like we do electrocardiograms?
Okay, with regard to intermittent fasting, I don't think you can say that, with fat, you can't just say that one way of decreasing fat mass is going to specifically target some depot of fat, right? Whether it's visceral or in the subcutaneous compartment. What I have noticed, because I haven't seen any studies on this, but what I notice is that it really depends on the individual. Someone can lose a lot of fat mass and most of it is subcutaneous. And then you have someone else who looks like, they didn't lose any weight at all. Maybe they didn't even lose, very much in percent body fat, but it's all coming from that visceral component. So that seems to vary greatly. We do know, back to Larry, I have noticed that exercise does seem to help with decreasing the visceral fat depot. So what I like to do is make sure that we combine both elements. You're addressing obviously the diet, but hopefully maybe that the exercise will help. And they always talk about the sumo wrestlers, right? Who are, packing on the carbs because they need that size. And they are metabolically healthy until they retire because they have extensive training regimens, and it's pretty hard to be a sumo wrestler. It's a lot of work, and they train all day. But the minute they retire, they still have that fat mass, right? And now they're not having that exercise or training component. And now we see the metabolic dysfunction start to creep in. So if you take that example, then exercise, I think, has a big role. In terms of whether we should be doing a Dexa, I think so. I mean, the amount of radiation you get is equivalent to 1 day's normal radiation, natural radiation. So if I were to fly to where Larry is, I would be about 1 week's natural radiation. So it's really very low. And I think it's very available because you do it with the same machine that you do bone density with, just that people are not aware. And I think that would be a good screen. But what about if you are in a place where you just don't have that kind of technology available? Then just very simply, my patients know how to do this. If you can pinch it, it's subcutaneous. You can't pinch it, so they're always trying to pinch their bellies, right? You might have loose skin, but they get very good at learning, where the fat is, right? So I think that's something we hardly put our hands on patients anymore, sadly. But, you should be able to tell when there's a good subcutaneous compartment versus, I think this is all visceral. And there are some bellies that you can't pinch anything. Everything is visceral, right? And then a simple string test or measurement IDF uses that just very simply for metabolic syndrome, right? I think it's 31 inches for women, and I think it's 37 for men. If you're above those numbers, then you have metabolic syndrome. So I had 2 patients once, and they asked me this question, well, how do we know? And I go, well, I give them the whole waist circumference thing, and they looked at each other and they went, yeah, we got it. So that's a simple way. And I think we need to start talking about that with our patients more.
So Vyvyane, you made a point on the chat yesterday during the discussion that you're obese with a BMI of 25 and an Asian. And so why would the 31 and 37 inches apply to all populations? Shouldn't we be adjusting our thought processes for different populations with different numeric levels?
Absolutely. Now you're speaking my language, right? Because that's the other thing that frustrates me is we treat everyone the same, and we aren't looking, and we talk about racial disparities, but we don't talk about ethnic differences in cardiometabolic health. And that, we talk about racial disparity, it's this big thing, oh, it's policy, it's social, but, if we come down to our field, we really should know these differences physiologically between different ethnicities, right? Just with insulin, for example, if you're African American, then you have more likely, just at normal glucose tolerance, you have higher insulin, right? Much higher, and your insulin sensitivity is a lot lower. If you're East Asian,
freeze?
Oh, did
Am
I
I the
freeze?
only one with Vyvyane freezing?
Can you all hear
Or
me?
is it me who's?
Yeah,
I can hear
we
Vyvyane.
can hear you. It's okay.
Everything's working.
Okay.
Yeah, and just going back.
Cut
you look
off
at
on mine, but maybe it's my internet connection.
Okay, so African Americans, but if you look on the other end, East Asians, very insulin sensitive, not making a lot of insulin. They don't make as much, they just don't, but they're very insulin sensitive, right? So we should, just these simple differences we're not even aware of. So yes, we definitely need to take into account those differences. With the BMIs, yes, it is ethnic specific and country specific. So if you are South Asian, 25 BMI will put you in the obese category. If you're East Asian like me, 27, right? If you're African American, most of my African American patients, I like to keep them at 28, 29, because they have more muscle mass and you don't want to mess with that. So you really need to start thinking in a more nuanced, like Dale said, we have to be more nuanced in our thinking. And there's this tendency to, this will fix it or that will fix it. And we're really much more complex than that, thankfully.
So that gets us back to the targeted interventions again. And Marco DeMario has a question on the chat for Jennifer. Wanting to know, how difficult is it to prescribe a treatment before any sign of clearly manifest disease regarding preventative targeted interventions, for particularly if it involves certain types of more invasive or intensive lifestyle intervention?
I think this is certainly the goal. Prevention is a tough thing here in the US. I think that's not a surprise to anyone. We've seen this play out over the last 18 months. It is difficult to get people to adopt things that are not easy, especially like longer term lifestyle change is not straightforward. We see that in, as Vyvyane has said, if up to 90% of people are metabolically unhealthy in the US, it has not been something that has been successfully applied. It is easier to get people usually to take medications than to change their lifestyle. But even in that setting, we have drugs that can prevent breast cancer, selective estrogen receptor modulators, aromatase inhibitors. Studies have shown that only 10% of people who are deemed at high risk of breast cancer, so this isn't even just population-based risk, will take those drugs. And of the 10% that start them, less than 50% complete a course of a recommended duration. So it's unfortunate, but it does speak to the fact that if we are going to find strategies that are actually scalable on a population level, we can't be telling people that you need to lose weight or you need to exercise regularly, eat well. Those are really great goals, but it's just not feasible. So if we could find things that for an individual person were more likely to be beneficial, that were not so global, like for an individual, if strength training made a difference, if we could identify better, and I think this gets to what Dale was talking about too, being able to identify that individual who has a risk based on a particular characteristic, that would be I move this field forward tremendously. And there are studies going on that will hopefully help us get there. But at this point, especially lifestyle interventions that are more intensive have really not been demonstrated to be sustainable for people. And there's very low levels of uptake, unfortunately.
So I'm glad you brought that up, Jennifer, because one thing that I always talk about here in my clinic is this. Look, when you give a recommendation to a patient, the first question I ask is, can I do it? Can we do it? If we can't do it, we have no business asking the patient to try to do it. So that's the rule here. Whatever we implement, so yes, I do focus a lot, Jay, on lifestyle, but it starts here. And the team, thinks of an intervention, and then we go, okay, you got a week, you got 2 weeks, and we see how we do. And of course, we're collecting data on our own performance. First of all, I will see all the obstacles my patients will come up against, right? Because likely I will bump up against those same problems. But, and then I will figure out, then I have my team say, oh, I couldn't do that because I was too busy. Well, your patient's not too busy. They're busy too. Good, right? Figure it out, because if you can't figure it out, yeah, you can't be saying a patient is non-compliant, because you know what? That means you're non-compliant too. So that's the category I think that makes us uncomfortable, because we're not willing also to look at our own behaviors. It's always easy to point fingers, right? And my patients know I never ask someone to do something that I'm not willing to do a trial workout on my own. And if I can't do it, I don't ask the patient to do it until I figured it out. So I think that component is really important. So if we're going back to cancer, for example, we know that alcohol is a group 1 carcinogen. It's on par with tobacco and asbestos. Group 1 means no safe lowest dose. How many cigarettes would be safe for me to smoke? 0. Well, how many glasses of wine would it be safe for me to drink? 0. Okay, now let's just turn the camera back on ourselves, right? How willing are we to go to 0? You think of all those physicians in the 1950s who were smoking in the consultation room, right? And we laugh at them and we make jokes and we go, oh yeah, I remember those days. And then now that's us. So I think that, we talk about silos and breaking down silos. A big silo is that silo between the provider and the patient. And that's where I think maybe we need a little bit of self-reflection. I'm just challenging myself. I found that I needed to humble myself and to realize that, look, if I can't do it, what's my business asking my patient to do this? So I think with lifestyle, we could start with that. We would all go a lot further.
I think on next year's panel, we need to have a representative from the nation of France to give a counterpoint to your comments about alcohol intake, as well as a few other parts of the French lifestyle. The last time I checked, their longevity is quite all right. And we have to look into that in a very serious way. But I completely agree with what you're saying. We have to look into ourselves. I think we, on the medical side, really need some instruction. I'm always quite amazed at how well the world of advertising does well to modify behavior. One of my favorite commercials is a man wearing a wearable. Jay will like this, and he's a rather stout man. And he's in a restaurant and all these scolds are around him, his spouse or his mate, all the other people at the table. And he checks his device and his glucose is quite acceptable. And he takes a spoon of pasta and he offers it as if he's offering it to his wife, who has a scolding face, and then he puts it in his own mouth I think it's extraordinary. If we could get people to modify their behavior and have some fun with it, it may be a game changer. So this man was having fun with maintaining a good diet, keeping his glucose in range, and enjoying a little forbidden fruit, so to speak. In his case, some carbohydrates. Anyway, I really think that we need help in the medical profession. I heard a lot yesterday that was begging to go back to the old-fashioned house call. You know, people like hands-on and attention. Maybe we need to do it as we're doing this conversation amongst ourselves all over the world with some virtual help. But attention matters, and humor matters. We don't just have these various humoral immune responses, and the ophthalmologists have their aqueous and vitreous humors. We need humor. It's a fantastic tool, and but we need to be smart about it. And unfortunately, since we're so good at putting the elements of Krebs cycle on answers to tests, we may lose our sense of humor as we progress in our profession. But I don't want to leave small things like that out. And then there's other accompaniments, sleep and obesity. I think we all remember as house officers gaining some weight because we were deprived of sleep, and they would feed us midnight meals, which we would pack in. Anyway, I can easily digress, but I think we need some lifestyle changes among us as healthcare providers.
You know, one of the people on the chat comments that one of the benefits of the Mediterranean diet may be the wine that goes with it. And yesterday we talked about having red wine with chocolate-covered strawberries as a potential benefit. So, you know, there are those kind of things, but and everybody criticizes smoking, but in Miami, I have a great deal of problem trying to convince my patients, particularly Cuban patients, that they should stop smoking Cuban cigars. And they may only have 3 or 4 a week. They're not inhaling them. And I'm not sure there really is a quantifiable benefit or risk for either cigar or pipe smoking. The risk is clearly documented for cigarette smoking, but the occasional Cuban cigar or the person who uses a pipe, I have trouble trying to counsel them not to smoke.
Other than nasopharyngeal cancers, which are still an issue with those types of activities, one has to remember that a botanical called nicotine has an immense receptor system all over our body, the nicotinic acetylcholine receptors for one. And there are actually a couple of diseases that shouldn't be taken lightly where there's actually, in a very peculiar way that just knocks people off their chairs, ulcerative colitis, there's a protective effect from nicotine. And there may be a protective effect in Parkinson's, and there may be a protective effect in schizophrenia. I'm not advocating smoking, but the metabolic pathway involving that botanical substance known as nicotine is programmed in our immune system, in our brain. I don't know about fat cells, but I bet it's there too. And there's an immense amount of activity, of course, in the pharmaceutical industry, so far unsuccessfully, to modify nicotinic acetylcholine receptors. I'm talking mainly about alpha-7 types, but it's another example of a terribly forbidden substance having a Janus face of benefit in some circumstances.
Dale, what pathways do you think nicotine is either pro or con as it having impact? Dale?
No, I was actually going to make a comment in that, and I think that one of the concepts that this conversation is bringing up is this whole concept of hormesis, right? So in other words, you know, one of the reasons, for example, why some degree of exercise is good is because you actually damage some cells in the process and then you get regeneration, right? And it kind of builds back better in a way, right? And so, I think that there is, significant precedent to the concept of, small exposures to some things that you then have to respond to potentially can build resilience. The challenge is kind of defining what's the appropriate dose, what's the appropriate frequency, etc. I think one of the issues with whether it's smoking or overnutrition or obesity, or even I would say over-exercise, right? That it's figuring out what is the right dose, what is the right frequency, what is the right gap to allow the organism or the individual to actually repair and to become more resilient. And so I think that really kind of speaks to the challenge of everything that we have been discussing is, on the one hand, I think we'd all agree that if you kind of constitutively activate any signaling pathway, it then becomes maladaptive. It either desensitizes or you get, some other change that then the cell has to adapt, and then you kind of pile on, maladaptation upon maladaptation, and then you kind of really have shifted homeostasis out, to the extremes in a way, right? And therefore, I think that one of the challenges is going to be trying to figure out how do you kind of quantify those small degrees of risk with significant degrees of benefit. And I think that that's a very interesting perspective to have as we think about prevention.
Yeah, yesterday, one of our esteemed guests in a fireside chat, who's an avatar of exercise, told us the story about developing osteoarthritis, having to have a knee replacement after doing so much running, and has now taken up bicycling, which everyone in Amsterdam would say, we do it all the time anyway. There's a very low level of obesity there.
Right.
But back to what Dale was saying, it's true. We need to, kind of figure out the doses and so forth, right? So with regard to nutrition, for example, we just kind of seem to be dispensing nutrition advice. And sometimes it's based on the RDA, and sometimes it's just based on our perception of what is healthy, right? We always tell our patients, I hear this a lot. I listen in a lot when I hear providers counseling patients, and I often hear the term, I think it would be great for you to be on a low-fat Mediterranean diet. That's not possible. A Mediterranean diet is usually moderate or high-fat, and I have gone through the Mediterranean and asked my friends from all those countries what they eat, right? So what are we saying when we tell someone to be on a low-fat Mediterranean diet, for example? And then the quality of fats, right? We know that the omega-6s are highly inflammatory, and we tell people to pile on the nuts and the seeds, right? Without, thinking about what that might have, what effect that might have on the body. So if an almond, which we all think is healthy, has 2,000 times more of the unhealthy inflammatory omega-6s than the omega-3s, are we really doing the patient a service by telling them to eat almonds, right? And actually, there's a preponderance of omega-6s in the diet, not just with processed foods. If you go out to eat, they're going to use the cheapest oils. They're all seed oils, sunflower, peanut, that kind of stuff. And that's all omega-6, for example. So if we're not taking those nuances in, what I'd like to see are really good RCTs for nutrition. And we're always basing our nutritional recommendations on just epidemiology, right? And usually association. So we see an association with this or that, and therefore this is causative, which, if we were to use the same logic, well, every time I see a doctor, I see sick people. So doctors are causing people to be, well, maybe that's might be true sometimes. I don't know. But, if we're just going with that association studies, then we're really falling behind. And that's where I would like to see more research, more money, looking at good RCTs so that we can give actually evidence-based dietary recommendations.
Excellent. So I'd like to ask everyone else, how do we get to the point where we can have individual, personalized recommendations and apply them universally? What other what data do we need for the population to be able to do that? Is it only pinching the belly and looking for visceral fat, or what are the array of things and kinds of information we need to make personalized recommendations about lifestyle? Anyone?
So I'm going to maybe just kind of, start with a few, just a very high level perspective, which is, it's first of all, it's very difficult because, there's so much, variation in humankind, right? In terms of both, genetics, epigenetics, metabolism, etc. But having said that, and, and reflecting on, again on this conversation and thinking back, what was one of the most effective things ever done to give this significant increase in lifespan? It was clean drinking water and safe sewage, right? So in other words, I think that there are things that you can do at a population level that even, you could argue at an individual level, the effect might be variable or small for some, but big for others. And I think that, issues, relating to food supply, right? Relating to really eating less processed foods and more sort of natural foods that you have to work to digest, right? Issues related to things like having communities that are more walkable, so you can maybe walk to the shop rather than driving to the drive-through, right? Things that we have kind of given up because it's just inconvenient, right? Or because our lifestyles are such that it's just more easy to do that rather than to do something else. Issues around sleep hygiene, etc. I mean, things that actually, I think nobody would argue could have very large population effects. I think that is a conversation that sometimes gets pushed to the side as we kind of go for, that precision target, right? And I agree that, at an individual level, you may have 10 people and, one person may get a marginal benefit from all those lifestyle adaptations, but 6 or 7 people may have a somewhat bigger benefit. And at an overall health level, then, we ultimately will see the benefit. So I think that's a perspective that we don't want to lose, even as we really still hone in on trying to get to some of those precision biomarkers, etc. But I would argue that some of that really ultimately is for the individual, not necessarily for the population.
I would agree that there are different issues on the population level and the individual level. I think on the individual level, there's a motivational piece of this, that having that ability to prescribe would be incredibly powerful. Like, we do see that when somebody is diagnosed with cancer, their willingness to make lifestyle changes is dramatically different than in the prevention setting. And many people, we just did a study through the American Society of Clinical Oncology where we surveyed people who had been diagnosed with cancer within the last 10 years and found that 74% of them reported that they had tried to change their lifestyle to make their outcomes better. Even though we don't have the clear evidence that a specific change in lifestyle will produce that for people, 74% of them said that they were trying to eat in a different way or exercise more or change their weight in order to prevent a cancer recurrence. Certainly don't see anything like that in terms of initial prevention. So, I think that we need to think about how we motivate people to make the changes. Dale, I completely agree that as a society, we need to make this easier for people. Even when we have the evidence at times, it's difficult to get the support for it. For example, we have so much evidence that exercise, once someone is diagnosed, will make their treatment more tolerable, will help prevent the type of debilitation that people often have after cancer treatment, especially as people age. And yet there's no third-party payment for exercise as a part of cancer treatment. So, I think that there are things that we need to do on a societal level, but having that ability to have when we're talking about primary prevention, I wish that we could get the whole population to behave in a healthier way if we could all decide on what that meant. But I think that being able to identify risk in individuals and help them figure out a strategy to mitigate that would be very powerful in getting people to make these changes.
Vivienne?
Well, someone in the chat asked right at the beginning, how difficult would it be to prescribe a treatment before any signs of the disease are clearly manifested. And I think that's the issue here, right? As clinicians, we really can't do anything. We can give advice, and like Jennifer said, that's not going to be reimbursed, and you know, you have your 10 minutes. So good luck getting in all your advice in 10 minutes. So, you know, you're trying to address that, and you're trying to make that a focus and to emphasize the importance for the patient. The patient, however, is like, I'm fine. There's nothing wrong with me. Maybe my weight's not, I don't fit in my pants the way I should, but there's nothing wrong. And so there's this sense of, well, you know, I can't see what's going on inside. But what was really effective with those anti-smoking ads was that we kind of made visible what was going on inside the body. So you remember the blackened lungs and so forth, right? That was very dramatic, but it really had a great impact in terms of this public awareness of what smoking could do to you. And I think with metabolic disease, it's just sort of, and again, then we're just judging by size. So someone's big, then maybe they're unhealthier, but I'm not as big, so I must be healthier, that kind of stuff. So, you know, I used to be against using extensive biomarkers, for example, to you know, kind of address a patient's issue. But I find that a lot of times I know that the marker isn't for me. I don't need the marker to know that you have a metabolic dysfunction and we need to change some very basic things, as Dale was saying. It's more for the patient, because when they see the red, you know, sort of lab values, whatever, that's when they start going, oh, there must be something wrong. It's in red, right? We respond to that. So it's more to convince the patient because they can't see what's going on inside them. So we often will kind of go to extraordinary lengths to try to turn that focus onto what might be going on that they can't visualize. And only when you get their attention that way, like Jennifer said, if nothing's wrong, I'm not going to treat anything, right? And then this idea of everything in a pill, you're absolutely right. They prefer everything in a pill. In fact, I have a lot of patients who come to me and they're on medications for diabetes, high blood pressure. Do you have diabetes? No. Ooh. Do you have high blood pressure? No. And, you know, if you investigate, they tell you, well, you know, yeah, my pressure is normal, but you're taking all these medications. Yeah, so I don't have it anymore. Wrong, right? But that's we have to start thinking about what they're seeing, right? And that's what they see. My pressure's down. I'm good. I don't have it anymore, right? I see that a lot.
Well, you raise an interesting point of not having enough time in 10 minutes to do all the prevention things, and the prevention things don't get paid for. But that's not always the case. If you go to Medicare Advantage programs, my brother-in-law happens to run a large Medicare Advantage program. What they do is their clinicians spend 25 to 40 minutes on each encounter so they can pay attention to the preventative things, because the only way that a Medicare Advantage program is profitable is if they keep the patients in it healthy and out of the hospital. And so they bend over backwards to do the preventative things and take more time to be able to do that. And maybe that's a commentary that you're making, that 10 minutes isn't enough, that we really ought to be expanding the time allocated to primary care visits to anywhere from 25 to 40 minutes in order to allow everything to take place that's needed if we're going to be preventative.
But that is often not under the clinician's control. This is my problem, right? If you are functioning individually, independently, then yeah, but it's often not under your control. And
No,
that is the dilemma for
the head of our University of Miami health system told me that I had to stop seeing new patients for an hour and return patients for a half hour and cut those in half. And I said, I won't do it, because I can't treat diabetes if I'm limited to that kind of time frame. And I resisted it and I surveyed around the country to others and demonstrated that you really do need to have that time to do it. And I think we need to really be putting pressure on the systems to allow more time for primary care visits so that we can incorporate prevention. Otherwise, the things we're talking about are hopeless. We can't get them done.
So I speak to a lot of physicians on this, right? And I'm not always in the position they're in. I had to leave the system, you know, ultimately. But a lot of them have a lot of debt. they have families to raise, they have young kids, and many are afraid to go out on their own. They're afraid to lose the network that their system might provide. So for clinicians, this is what I see my colleagues struggle with. And there's, as we all know, huge burnout rates in providers. And I would say it probably is worse for primary care providers. So, I think that we know this, and we kind of give lip service to it a lot, but we don't actually address the root causes for that. So we're always talking about, the burden of administrative work. I mean, I think we have the system where it's most expensive clerks in the world, because you have these well-trained, brilliant physicians, and they're there, type, click, 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 right? That's all they're doing. You're paying them, I don't know how much per hour just to do that. So I'm not even sure if that's a great business model, right? But, you get to this point where these physicians are burdened, they get very burnt out, and they're unable to self-care. If you're unable to self-care, then it's really hard to start talking about prevention for other patients. And I remember when I was a resident, I remember walking into a room with this patient, and this patient was complaining about his bed. And he couldn't sleep, and he didn't like being in the hospital. And all I could think of was, man, I want your bed. I just want your bed. Because I hadn't slept in hours. So now I could not relate. This guy saying, it's so hard to sleep. I'm like, I can stand in a line and fall asleep like that. So I would love your bed. What are you talking about? You're a complainer, right? That was can you understand that? I mean, it was like, I couldn't take care of myself. So now I'm looking at this guy and going, yeah, wimp,
So what we need to do, we've only got a couple minutes left. I'd like to ask Larry, Dale, and Jennifer in 1 minute each, whether you have something further to say on what we've been talking about, or whether you're done. Jennifer?
I would just wrap up by saying, I certainly think there's a call for more research. I would really love to see cancer prevention studies be reinvigorated. We haven't launched new studies in a long time. And I think that the NCI has felt that from a cost benefit ratio, it is difficult to do these studies. So I think that we really need to push for new paradigms of these smaller, more agile prevention trials focused on groups that have risk because of a specific factor. I know we have some work we need to get there, but I think that, we've really sort of advanced cancer treatment, and prevention has really lagged. And I would love to see that move forward in the next decade.
Dale?
Yeah, so I would say that, we're on the cusp of, very exciting times where we will continue to get much more detailed insights into disease pathophysiology, et cetera. And at the same time, I think that this has to occur in concert with population level strategies that work for larger numbers of people at lower cost, so that maybe we can focus our resources on those, what I'm going to call the difficult cases, the outliers, the ones that actually don't respond to fairly simple paradigms. And I certainly endorse everything that has been discussed, that there really needs to be much more robust, both advocacy, et cetera, as well as, just education of both physicians, providers, and patients to getting the level of support and reimbursement for straightforward, simple things that we know will benefit many.
Absolutely. Larry?
Well, I would go to the idea of whatever we try, even when we're thinking about moonshots, to please keep it simple so that it can be implemented. Even simple things are remarkably complex when it comes to implementation. But I think this has been very helpful, and I just want to note that the sun also rises here in the West.
Yes, you started out very early, your time. It was 5:30 as we began. But what we've done is, I think, have a remarkably broad-based conversation from different perspectives. And we all ended up concluding, though, that the key in one form or another are lifestyle things that we really need to be paying attention to. And, we brought up a couple pharmaceutical things, nutraceutical things, but fundamentally, it was lifestyle. And I think that's an important issue as we think about it and as we conclude. And so I'm going to thank everybody for their participation, Vivienne, Larry, Dale, and Jennifer. And thank you, the audience, for being with us. And I'm going to throw it back to Zan and Thomas.
Oh, Jay, terrific. Thank you so much. And the panelists,